In this video, we are going to mainly discuss about pregnancy-induced hypertension. So PIH means pregnancy-induced hypertension. So first we need to see what is hypertension in pregnancy. So you can divide the hypertension in pregnancy into two types. Like the first, we need to see the blood pressure. If the blood pressure is greater than 140 by 90 milligrams of mercury, especially on two occasions, you will see not on one occasion, you will see two occasions with 4 hours apart. Okay, so if the blood pressure is greater than 140 by 90 in two occasions 4 hours apart, for every 4 hours you will see if again the blood pressure is rise, then you can confirm it's a hypertension pregnant female. Okay, so this hypertension is again divided into two types. That is, if the female is having hypertension less than 20 weeks and if the female is having hypertension greater than 20 weeks. So the female is having hypertension less than 20 weeks means what you can understand. Already this female is an hypertensive female even before the pregnancy. So even after the delivery also this kind of hypertension will not decrease. Okay, so this is a chronic hypertension case which is seen in a pregnant female who has conceived. Next, coming to greater than 20 weeks. If someone is getting hypertension greater than 20 weeks means it is a gestational hypertension. Gestational hypertension means this is also called as pregnancy induced hypertension. So this is the main one, pregnancy induced hypertension because of pregnancy, actually because of placenta. Placenta is having some abnormality, because of placenta there is hypertension, and here in this case the blood pressure will return back normal after 12 weeks of delivery. So after 12 weeks of delivery, in the case of gestational hypertension, you can see that the blood pressure will come back to normal. Okay, so this is pregnancy induced hypertension mainly because of placental abnormalities. So now this pregnancy induced hypertension is in turn divided into two types. That is gestational hypertension and other one is preeclampsia. So what is this? Let us understand. In the case of gestational induced hypertension or pregnancy induced hypertension, here as we discussed, the BP will be rise greater than 20 weeks and it will come back to normal 12 weeks. Important thing is here there is no proteinuria. There is no proteins in the urine or there is no end organ damage. That is, you cannot see any organ is damaged in the case of because of pregnancy. If you get hypertension, there will be no problem to the fetus and also to the mother. Okay, but in the case of preeclampsia, you will see the BP is rising greater than 20 weeks and the BP is again here also it is coming back to normal after 12 weeks of delivery. But here the problem is there is presence of proteinuria. The protein is present in the urine and also there is presence of end organ damage, or sometimes both may be present. So sometimes both may be present. So now let us differentiate the preeclampsia in turn into two types. So preeclampsia is divided into two types, that is mild preeclampsia and another one is severe preeclampsia. So in the preeclampsia there is proteinuria and organ damage or sometimes both. Okay, so mild means here the BP will be greater than 140 by 90 but it will never go above 160 or 90. You can understand now in the severe the BP is greater than 160 by 90, so very severe condition of preeclampsia. So gestational hypertension is normal, no problem, but preeclampsia is a very big problem because here there is proteinuria and organ damage and it is in turn divided into mild, severe. Mild preeclampsia is also not such a problem because there is no end organ damage here, no end organ damage. But in the case of severe preeclampsia, there is a sign of end organ damage. So this is very important. So if end organ damage in pregnancy, you can understand it's a very big problem. Now coming to chronic hypertension. There's another case called chronic hypertension with preeclampsia superimposed. So what is this? In this case, a female is having hypertension and suddenly develops at 20 weeks. At 20 weeks, suddenly she may have high uncontrolled BP and suddenly she may have proteinuria, suddenly she may have end organ damage. So this is called as chronic hypertension superimposed by preeclampsia. Actually, this case is like you can consider it as gestational hypertension, because at the 20 week it has come, but suddenly in this female there is also preeclampsia. So it is nothing but a mixture of preeclampsia and gestational hypertension. That is this chronic hypertension with superimposed preeclampsia. Okay. So the BP is rise suddenly in 20 weeks. Suddenly the proteinuria is happening. Suddenly the end organ damage is also happening. So now we need to see what is eclampsia. We discussed about preeclampsia. Then what is eclampsia? Eclampsia is a case where you see there is severe preeclampsia with pre means you can understand before eclampsia, right? So there is preeclampsia and also there are generalized tonic clonic seizures. Tonic clonic seizures. So seizures are present in this patient along with preeclampsia. This is severe. So you can understand already there is severe preeclampsia. Severe preeclampsia means greater than 160/90 and also end organ damage and also tonic clonic fever. So preeclampsia is a very big problem. Okay. And one more thing you need to remember that the severe preeclampsia may give rise to two problems. One is eclampsia as we see just now, and another one is HELLP syndrome. What is the HELLP syndrome? That is also I am going to discuss now. Okay. So remember, severe preeclampsia have a chance to produce eclampsia and also HELLP syndrome. We discuss eclampsia, there is severe preeclampsia with generalized tonic clonic seizures. Now let us discuss about proteinuria. So we are saying that there is proteinuria, end organ damage in the case of preeclampsia, severe preeclampsia, right? So what is that? Proteinuria means whenever you see in a dipstick method, the values are greater than or equal to +2, then you can confirm it as proteinuria. And in a 24-hour urine protein excretion, if you see the protein content is greater than 0.3 gram per liter, then you can confirm. And if the urine protein is to creatinine ratio, if that is also greater than 0. or equal to 0.3 gram per liter, then you can confirm proteinuria. So three conditions to confirm proteinuria: a dipstick method which is greater than +2. Okay. And in the protein 24 hours in the urine, how much protein is coming? Greater than 0.3. Urine protein is to creatinine ratio greater than 0.3. All these conditions you can confirm proteinuria. Now coming to end organ damage. So actually what organs are damaged? Let us see. First, the platelet count. The platelet count is less than 1 lakh, then it is end organ damage. And when serum creatinine is greater than 1.1 milligrams per dl. Okay, when serum creatinine is greater than 1.1 milligrams, and if liver enzymes are raised two times than normal, then it is leading to end organ damage. And any presence of cerebral or visual symptoms. Okay, so this is also end organ damage. And you have pulmonary edema. So very important, these are all related to end organ damage. So what organs are damaged here? First you see platelets. Okay, next you see serum creatinine, means it is related to kidney. So kidney may damage, liver may damage, brain may damage, eyes, visual, and pulmonary edema, lungs may damage. So like this you can remember end organ damage: platelet count less than 1 lakh, serum creatinine less than 1.1, liver enzymes are 2 times, means liver is damaged. Next, cerebral and visual problems. Next, pulmonary edema, lung is damaged. So now let us see what are the signs which are impending eclampsia. So what signs? If someone is having eclampsia, what signs you will see in them? So first sign you see is epigastric pain. So severe epigastric pain with some nausea, sometimes may present, sometimes absent. Vomiting due to subcapsular hematoma. Remember, vomiting is due to subcapsular hematoma. Okay, vomiting is due to subscapular hematoma causing liver capsule to stretch. And sudden onset of headache which is not responding to usual treatment. Actually, it's a sudden headache that if you give headache treatment, it is not working. Along with that, there is dizziness. Why dizziness? Because of cerebral hypoxia. So this case is a eclampsia, signs of eclampsia. And there is new onset of visual disturbances like scotoma, diplopia, blindness, also be blurring of vision. This is all because of hypertension, retinopathy. So this blinding of vision will come back again after the delivery when the hypertension is dropped. Okay. So that is Keith, that is important, Keith, Wagner, Baker, Keith, Wagner, Baker. You can remember like some Baker. Okay, here's a Keith, Wagner, Baker classification. According to that classification, there is a hypertensive retinopathy. So what is the next step to be given to prevent eclampsia? Actually, if you prevent the eclampsia, you can prevent the convulsions in the patient, right? So to prevent the eclampsia, you use magnesium sulfate as a treatment. Okay, primary treatment, magnesium sulfate. Now let us discuss about HELP syndrome. So what is this HELP actually? Who is going to help here? Let us see. HELP syndrome, the patient complains here also epigastric pain, but in the right, somewhat in the right upper quadrant, especially in the third trimester. So how you can differentiate between eclampsia signs and HELP syndrome is, in the HELP syndrome, especially during the third trimester, if someone is saying there is epigastric pain, especially right upper quadrant. Okay, so here H stands for hemolysis. Okay, hemolysis, any two of the four may be present, like there are four signs of hemolysis, like in the peripheral blood smear you will see schistocytes. Already about this I discussed in liver diseases, right, in pregnancy. Schistocytes or helmet cells or Burr cells, so these are seen in peripheral blood smear. Okay, and serum bilirubin will be greater than 1.2, that is indirect bilirubin will be high, and haptoglobin will drop, and LDH values will be greater than 600 international units. So if you see any of the two in this, then you can confirm as hemolysis. Next, coming to EL. Here EL refers to elevated liver enzymes. Liver enzymes are increased, like about SGOT, SGPT are increased. SGOT, SGPT are increased greater than 70 international units. Okay, and LP here represents the low platelet. Platelet is decreased less than 1 lakh. Okay, so what is the Tennessee criteria for diagnosis of L syndrome? Tennessee criteria, just take out this LDH here. LDH greater than 600, SGOT, SGPLT greater than 70, platelet count less than 1 lakh. Okay, so this three, all the digits, nothing but all the numbers. LDH greater than 600, SGOT, SGPT greater than 70, platelets less than 1 lakh. This three together are called as Tennessee criteria. Tennessee criteria for diagnosis of HELP syndrome. So in 85% of patients of HELP syndrome, you will see there will be high blood pressure. Okay, and in 15% of HELP syndrome, you will see BP is normal. So remember that 85% of them will have high BP. Okay, so the reference ratio is 4 to recurrence. Sometime it may recurrence, that is 4 to 7% again recurrence. So HELP syndrome is most common in multi-gravida female. Multi-gravida means it is not her first pregnancy, already she is having multiple pregnancies. Okay, so in multi-gravida female you will see this. And PIH and preeclampsia. PIH means pregnancy induced hypertension, and preeclampsia, those are common in primigravida. Okay, means in primary pregnancy, but this HELP syndrome is seen in multigravida. So like you can remember, in the primary gravida there is no need of help, but from multigravida there is need of help because it's a multigravida. Okay, so now let us differentiate between HELP syndrome and acute fatty liver of pregnancy and end this. Of course already I completed, let us revise it. Just HELP syndrome, more BP, that is in 85% cases. There is presence of proteinuria in HELP syndrome. Platelet count is low, but coagulation failure is not usually seen. But in the case of AFLP, that is acute fatty liver of pregnancy, there you can see hypoglycemia, hepatorenal syndrome, ammonia is increased leading to encephalopathy, and there is a feature of DIC with prolonged prothrombin time. About this already I discussed in liver disease, so just I am saying it orally. Okay, and secondary complications like pancreatitis, diabetes insipidus are seen. And here in the acute fatty liver, there is only blood pressure increase in 50%. So here 85% in the HELP, there only 50%. So while this we completed part 1 of our PIH, next we'll continue with the second part in another video.